Well, hello and welcome to you all. Thank you very much indeed for joining this event, which is entitled The Staggering Cost of Doing Nothing, Implementation of RSV Programs in Europe, in which we're going to consider the findings of the soon-to-end project known as PROMISE, which stands for Preparing for RSV Immunisation and Surveillance in Europe. RSV, of course, being respiratory syncytial virus, which is a common respiratory virus. And although often mild, it can be very serious, especially for infants and for older adults. It's estimated, in fact, that some 118,000 children die each year from RSV across the world. And here in the Northern Hemisphere, we're experiencing, of course, a surge in winter viruses, with headlines expressing concern about the prevalence of RSV and indeed some of the problems of accessing the available vaccines. And even non-severe cases of RSV are having an impact on families. They can keep people off work when they've got this condition, and it adds pressure, of course, to outpatient services. Well, the PROMISE project was set up by the Innovative Medicines Initiative, IMI, bringing together scientists, clinicians, public health agencies, the pharmaceutical industry, and of course, patients. Well, today for this event, we have gathered a similarly wide range of experts to discuss the findings and the achievements of that PROMISE project. And we're here to call on stakeholders, especially policymakers, to translate those findings into tangible actions. The event is being recorded, and when it comes to questions, you can submit them on the Zoom platform Q&A. Your name's not going to appear on screen unless you'd like to be identified. Anyway, to set the scene, I'm very pleased to welcome Harish Nair, who is Professor of Pediatric Infectious Diseases and Global Health at the University of Edinburgh, and he is a PROMISE Project Scientific Coordinator. Over to you, Professor Nair.
Thank you, Sue. Hello, and on behalf of myself and my co-coordinator, Professor Louis Bond, from the University Medical Center Utrecht and the entire PROMISE Consortium, a very warm welcome to all of you joining us today online. And many thanks to the MEPs who've taken time out from their busy schedules to participate in today's meeting. We are very much grateful to you for this. Just to give you a brief background, Sue has already given you a lot of statistics and background, but RSV is the leading cause of hospital admission in winters in infants in Europe. It's also the second most common infectious disease after malaria as a cause of death in young infants globally. And most of these deaths occur in resource poor settings, about 97% of the RSV deaths. We've previously estimated within the rescue project that every 2 minutes, 5 children die from RSV worldwide. And this is just putting Sue's, the statistics that Sue reported in a different sort of context. Since the initial setbacks for developing an RSV vaccine in the late 1960s, it was always an uphill task to develop a vaccine against RSV. And in 2015, the WHO Product Development for Vaccines Advisory Committee, or PDVAC, highlighted RSV as the most likely big new vaccine area with a vaccine likely to be available in the next 5 to 10 years. And it's against this backdrop that the Innovative Health Initiative, then called the Innovative Medicines Initiative, funded the RSV Consortium in Europe, or the Rescue Project, which started in 2017. Which was then succeeded by the PROMISE project. And we are today here in this sort of fortunate position where we have multiple products for RSV immunization targeting populations most affected by RSV, that is the young children as well as the elderly. The rescue and PROMISE projects have generated substantial evidence that have been extremely influential in informing decisions in the support of RSV immunization, particularly by the Gavi and WHO at the global level, as well as by several NITAGs, including the Joint Committee for Vaccination and Immunization, or the JCVI, at the European level. This policy summit now allows us to showcase some of our achievements to the MPs and the MEPs and have a dialogue with them to understand what else needs to be done so that those who are at high risk for severe disease can be protected. With this, I hand you back to Sue, who will lead us through the rest of the proceedings this afternoon. Over to you, Sue.
Thank you very much indeed, Harishner, for that introduction, for setting the scene so well for us. So let's firstly go then. The first panel, we want to understand a bit more about the burden and the impact of RSV and the added value of EU cooperation, because, of course, the implementation of health policy is a national competence. Member states are responsible for their own provision. So a big welcome to our four speakers. We have with us Michaela Odemuir, who is the chair of the European Lung Foundation's, ELF, Patient Advisory Committee, a past president of EFA, that's the European Federation of Allergy and Airways Diseases, Patients Associations, and she's also has personal family experience of asthma. Joining us too, Terho Heikkinen, Professor of Pediatrics at the University of Turku in Finland, currently a scientific advisory board and executive member of the Global Respiratory Syncytial Virus Network, also chairman of the Nordic Research Network for Pediatric Infectious Diseases. Two, we have Dr. Eduardo Colzani, who is principal expert on respiratory viruses and Legionella at ECDC, that's the European Centre for Disease Prevention and Control, based in Stockholm. He has a master's degree from Harvard University in Public Health. And Philippe Beutels, founder and director of CHAIRMED, which is the Centre for Health Economics, Research and Modelling of Infectious Diseases, also a senior visiting fellow at the University of New South Wales in Sydney, and a regular advisor to the World Health Organization, lead author indeed of the WHO's Guide on Economic Evaluation of Vaccinations. Now, we're going to hear from each speaker, but we do want to take your questions from the audience. You can put those in as you think about them into the Q&A function on the platform there. So do have those ready. We will take as many as we can. But let's hear first, I think, from the patient's perspective. Michaela, RSV then affects so many infants and older people more severely, and that impact then on parents and on caregivers must be really substantial. So what matters most to patients and those, particularly the vulnerable ones, with the RSV seasons kicking in?
Well, hello, and thanks for the invitation. Yeah, I would say to be protected and, if possible, also vaccinated, because the people who are already vulnerable, it's so easy then for people, when you make a decision, when you go to work or to a party or to a mall, and you feel a bit of cold and you think, it's nothing serious, I can go there. But when you meet me or my children who has asthma, the consequences are could be so big. It could be just a small cold, but it can also be that we end up in hospital. And I mean, people don't do that because they don't actually just think of the consequences. So this is really important to remember.
And what about the RSV as a virus? What makes it so challenging to protect yourself, and what can be done, and indeed with your own personal experience with your family?
Well, the problem is, like I said, it's all around us. So, and especially now when children get back to school or when we are mixing with family and friends, it's very hard to avoid. But of course, for a lot of people, it's not a problem because they don't think, like I said earlier, about spreading the virus and who it may impact in a more serious way. But when healthy adults get RSV infection, they can have, like I said earlier, a mild cold-like symptoms, but still, like I said, they can develop a lung infection or pneumonia. And sadly, the most impacted and vulnerable people groups, and you mentioned young and adults, there are also people with chronic conditions like me with asthma, COPD, bronchitis. It could be then a huge impact and damaging. And for them to catch this virus, it could mean a flare-up on their chronic disease condition, and we can also cause a short or a long-term impact. So people living with this condition were very protected during the COVID pandemic, We didn't meet with so many people, and so we were not exposed to viruses. And in addition, we were also more considerate and tried to protect those vulnerable. I would say it has now changed, and people now who are living with this, they feel like it has gone back like it was pre-COVID.
Thank you. And it's really helpful to hear from the personal perspective there. Turning to Professor Terhu Hakkinen, with your expertise on RSV and hearing there from Michaela about the personal experience, what would you say is the impact of the severe RSV and indeed the non-severe cases? And what about, is there any other evidence other than the PROMISE data that would support the burden that you see?
Well, thanks, Shu. To start with, I should say that during the past couple of years, there's been a huge increase in the number of studies and evidence for the burden of RSV, especially in young children. And right now, as we speak, I think we have ample evidence for the burden. And the overall burden in children, it could be divided into 3 levels, which perhaps it could be shown in a pyramid form. I'm not sure whether you can see the slide. Okay, let's start from the top. The absolutely most serious illnesses are treated in the hospitals, and that's the tip of the iceberg. From many studies, we know now that about 2% of children go to hospital with RSV during the first year of life, which means that 1 in approximately 50 children born in Europe will be hospitalized with RSV during the first year of life. It's an astonishing number, in fact. Still, that's only the tip of the iceberg, and the biggest burden or the bulk of the illness is in the outpatient setting. Based on several studies, both in Rescue and PROMISE and individual studies in individual countries in Europe, we know that approximately 30% of children will have an RSV infection during, and then they will go on having these RSV infections every year up to 3 years of age. And by 3 years of age, about 90% of children have had at least 1 RSV illness. Many will have 2 or even 3 reinfections during that time. And what is important in the outpatient setting is that RSV is the worst virus leading to ear infections as a complication. More than half of the children will have an ear infection, which in most countries leads to antibiotics. We certainly would like to avoid as much as possible. And then the third level is children who don't seek medical attention at all, but it doesn't mean that there is no burden there. A recent study showed parental anxiety and impairment of daily activities in children who have RSV, despite not going to see a doctor. And also work absenteeism is part of that burden there. But I would like, just for a minute, I would like to focus on the tip of the iceberg in the next slide, which shows the proportion of children in different age groups going to the hospital. And this is very much based on the PROMISE consortium. As you can see on the left side, 75% of all children who are hospitalized are less than 1 year of age. And then there's some hospitalization in 1 to 2 years of age. But then after 3, 4 to 5 years of age, there are very infrequent hospitalizations there. But on the right side, you can see the most important thing that I believe we should understand. And it shows the pattern of young infants going to hospitals. This is true, this same pattern is true to all countries, wherever you go, at least in the Western world, showing that the highest burden or the highest risk of hospitalization is for infants who are 1 month of age. And by 3 months of age, 60%, or that first 3 months of age, accounts for about 60% of all hospitalizations during the first year. And if you go up to 6 months of age, that accounts for about 80% of all hospitalizations. So if you really want to have an impact on prevention of disease, you should focus on these youngest infants here. Thank you.
Thank you. That really has set the scene, and those statistics are really very powerful. Particularly, it struck me about the 90% by 3 years old and that 1-month-old statistic. Turning to Dr. Eduardo Colzani, the European Centre for Disease Prevention and Control, ECDC, aims then to strengthen Europe's defences against infectious diseases. So how important is it for your organisation to collaborate and work with translational projects like the PROMISE project?
Thank you. No, it is important for ECDC, and ECDC has quite some experience in knowledge transfer, and this is also testified by also the new amended funding regulations that are giving further strength to ECDC to translate knowledge and evidence into actionable recommendation and advice to the member states. And this is also shown by the presence of many ECDC experts in EU, in boards of these EU projects, like PROMISE, for instance, where we mainly play a role in the sense of, first of all, making the project leads aware of the information and the data that is collected at ECDC. Also, the activities on the topic that ECDC is already performing to avoid any duplication of efforts, and also to find any synergy that we can then build on together to make a better outcome out of the efforts. And then, of course, the subject knowledge expertise of the expert involved. And finally, but not least for sure, is also the optional consideration of some of the outputs that are coming out of these projects to be transferred to ECDC once the project ends. So in this sense, we have quite a strong role, and we are happy this role even further. In addition, the amending funding regulation added also a stronger role of ECDC in translating basically research into action, and we are playing or we are expected to be playing a more and more a liaison role between the research communities and the decision makers on public health. So this is, but it also needs to be stressed, and it's important to be reminded that also ECDC has a strong independence policy and integrity policy that we need to follow, and this is also legally described. Therefore, we participate in this project, but we need to take into account this also because we saw in the pandemic the importance of the independence of ECDC in the trust that we are given externally and by the public in the advice that we provide. So we both cherish it, and we also need to respect it from the legal perspective. But other than this, of course, there is we're very glad to take on this type of information and roles in the projects.
Thank you. And I think it was very interesting what you touched there on raising awareness and making sure that the information that's available then does reach right across the member states and the European community. So thank you for that. Turning to Philippe Beutels of CHERMID then. So we've heard from other speakers just now about the burden of RSV, particularly for those more vulnerable groups. And considering your recent work on cost effectiveness of immunization, what is your work? What have your studies found?
Yeah, one of the main activities of our work in the Rescue and PROMISE projects was to establish and estimate costs and quality of life data, because these are necessary to perform incremental cost effectiveness analysis. So what we need is not just a burden in terms of the number of hospitalizations, the number of GP consultations and so on, but we also needed to know what the quality of life impact was of an infant being ill with RSV, the quality of life impact for the infant itself, but also for the parents in the household. So this was part of studies that we undertook, and we could establish that this type of impact was also for RSV clearly as important as for other infections that we regularly vaccinate against. So that's one element of the big puzzle that we have to make when we do cost effectiveness analysis. Another element is cost estimation. And as already been alluded to a few times, there's a bit of variation in Europe in how medical care is practiced. So the probability of episodes seeking medical care and seeking hospital care is different between different countries. And that is also a driver of the differences that we observed in the costs that we estimated by country. This is also part of the work that we did in the Rescue and Promise projects. And then, of course, we brought it all together in cost effectiveness analysis, where we apply different models to different countries. In the Rescue project, we applied it to 7 countries, where we estimated the impact of different uncertainties on the cost effectiveness outcomes that we estimated. And we found that the main uncertainties are especially related to the duration of effectiveness that we estimate for the intervention, so the monoclonal antibodies and maternal vaccination strategies, the timing of these interventions in the season, and intervention costs. As you can imagine, there are different options that we can look at with more expensive efforts of intervention, so more infants receiving the immunization, the more effective the program, but also, of course, the more costly the program becomes. And so there are different options that we can take by intervening in infants who are born outside of the season, before the season starts, so-called catch-up programs. We can also have year-round programs. Now, all of these programs, when we compare them to each other, they are very heavily influenced by the prices of these products. And so we've made the tools available for individual countries to use this type of evaluation to help them in making decisions for their country. At the same time, for older adults, which is the main focus of our work in Promise, we are still in the process of making more analysis as more data are coming in. But there, of course, there's also a lot of uncertainty related to the case fatality ratio, the duration of the protection, and also the price.
So that is absolutely critical, as you say, the cost effectiveness of the program, which is going to vary from country to country, depending on how the member states are putting this into practice. You've given some interesting data there. What about any evidence for very tiny babies, perhaps preterm babies?
Yeah, so we do try to make these analyses based on gestational age as we can, as much as possible. For high-risk infants, there is the possible replacement of the palivizumab by the new monoclonal antibodies. So these very vulnerable infants are, of course, at higher risk, and therefore targeting these products at these children is of pivotal importance for the cost effectiveness.
Thank you. Well, we very much want the questions from our audience, as I mentioned earlier. There's a lot of you sitting out there. We've got a fantastic attendance. Do pop your questions in. You have one of the most amazing range of speakers available to you. So get those questions coming in. You can pop them into the Zoom Q&A function, which is usually at the bottom of the screen there. A question coming in. Let's put this one to Michaela. A question has come in saying, how do you reach especially adults with the information about RSV? If people don't know perhaps what RSV is, the questioner is asking, saying that they're going to be less likely to get vaccinated. What's the best way to inform people about RSV? And this comes from Lise Creek from the RESVinet patient network. Michaela, what would you say to that?
Well, like you said earlier, in different countries there are different programs how you reach people. But in Sweden, when the child is born, like we saw on the diagrams, it's very important that the nurse that they may meet talk about this. And of course, we have a community, and I think widely we should speak more about the RSV virus. I don't think we speak so much about it as we should. So if the public know it more, and patient organization, of course, I represent asthma and allergy and lung diseases, we talk about it, but I think it's very important to talk about more widely, and especially, but also in schools, because if you have a child and then you get a new child, like we saw, it was very easy then that it could be if they have a cold and come home from school, and then the sibling get infected. So I think information could come in at different levels and very often, just to inform people about it. Like I said in the beginning, I don't think people understand how they can affect the consequences.
So Michaela, do you think then that responsibility for providing information comes from what, healthcare professionals, peer-to-peer parents, schools? Where would you like to see the emphasis?
Yeah, I would say from the healthcare, because it's about diseases. So patient organization, we can inform about it, but the information should in the beginning come from the healthcare professionals. But of course, everyone goes at least to the hospital when they have a checkup on their child or something like that, and then it's important to inform. And if there are many languages, it's important also to make sure that they understand what you're talking about. So I think this is also in a very easy language or brochures, but talk about it.
Thank you.
Watch Mitre.
Yes, exactly. And something like this where you're being able to give your personal experience is a fantastic way to spread the word. Perhaps, Teho, if I could come back to you, what about the burden of RSV compared to other circulating viruses like influenza for those most vulnerable groups, the young children and the elderly?
Okay, thank you. There are basically two questions there. Comparing RSV to influenza, if we look at hospitalization, it is clear by the current evidence that the rate of hospitalization of young infants because of RSV is about 7 to 8-fold higher than for influenza. So that's for the youngest infants. So the burden of RSV in infants is huge compared to influenza. And still, we think that influenza is important also. Regarding the other age groups, or especially older adults, certainly there is more and more evidence coming in that RSV seems to be a major player in hospitalizations also in that age group. And as we know, there is already a vaccine available, an RSV vaccine available for the older adults. The question is that or what I hear from different countries is that they would want to have more actual data on the rates of infections in that population, because the problem is that there have been few studies looking into the burden of RSV in that population and evidenced by viral specimens. So usually when the older people go to the hospital and they have an underlying RSV illness, they have not been tested for RSV, but now the world seems to be changing in that regard, and I believe that there will be lots of data in that population during the coming years.
Thank you. And thank you to everybody who's submitting questions. We'll take as many as we can. Sheena Mitchell has asked, do you think parents will accept maternal vaccination as readily as monoclonal antibodies prevention treatments for their babies? Who'd like to take that one? Is that one from back to Michaela?
I can try to answer. I think, again, if they have the information and the consequence, and if they don't take the vaccine, that's much easier way to approach people then. And of course, there are people who will be afraid of getting vaccinated. But again, when you know the consequence and how many people are affected, like I said earlier, and take help also from patient organization to inform about this.
Thank you. Anyone else want to pick up an answer to that question there? Philippe?
Yeah, I think there's a lot of studies that are currently trying to establish this acceptability of this young pregnant woman or mother choosing whether or not she's going to get the intervention herself or have her baby undergo the intervention. And I think from what I know about this, I'm not an expert in this particular aspect, I would say that there's a conflicting evidence to that point, but I leave it to the others to say more about that.
Thank you. Eduardo, do you have anything to add on that? Is that a helpful line of thinking as to whether you vaccinate the mother or the baby or both?
Well, it's of course what we know in general. It's the best way to protect newborns, and this is not the only vaccination that is offered to the mother. The acceptability is an important question, and of course, any type of intervention like a vaccination highly depends in the end of how acceptable and therefore how the uptake is to translate its effectiveness, when the effectiveness is there, into impact. So as it was mentioned by one of the other panelists, that the communication of the evidence and the communication of the information that is available is fundamental in order to make people aware of the benefits and the possible risk, of course, of any type of intervention, including this one.
Yes, thank you. A question from Katja Kilans is, if the diagnosis of respiratory virus is crucial, why is it difficult to implement molecular tests in the clinical settings globally? Terho, would you have a response to that? Getting that diagnosis right.
Well, I think there are two things there. One is the general awareness that is now increasing, even for the importance of testing. Usually people have thought that there's no reason to test, but perhaps the most important thing these days is the cost of testing. It's not negligible. And of course, when you're looking at things from the healthcare provider point of view, you have a certain amount of money to use, and you want to use it wisely. So it goes down to an individual country or even a hospital, how they change their practices. But certainly, as I said, the burden of children is so well known that there needs not to be much new data overall. But in the elderly population, there is a need for RSV testing so that we fully understand what is going on there. Regarding the maternal vaccination, if I may chime in on that question, maternal vaccination or the use of monoclonal antibodies, I would say that that's the million-euro question right now. And in every country, there are groups who are seriously looking into that question. There are pros and cons on both of those approaches, and certainly I guess that there will be mothers who would prefer to be vaccinated, but then there will be mothers who would prefer not to be vaccinated during pregnancy, but to give the monoclonal antibody to the child after birth. So opinions will differ.
Thank you. And again, it's about information. So another question that's come in from Anonymous, who attends quite a lot of events, I've noticed, asking, what about the burden of disease in adults then? Can we know more about RSV vaccines for adults? Philippe, would you want to pick that one up?
Well, adults is a very broad group, of course, and we know that people who are healthy and relatively young, so I would say under 50, there the disease burden is really very low. But once you go to older age groups, especially over 65, over 75, there the burden of disease becomes important again, as was already discussed. And when we did quality of life studies, we also compared flu with RSV in older adults. And we saw that the quality of life impact of RSV is comparable qualitatively to that of influenza, but it's recovering more rapidly. So the overall impact of RSV on the quality of life is lower in these older adults.
Thank you. And perhaps tying in with that, if I could come to Eduardo then, another question saying, well, then how do you drive government policies in Europe to mitigate the RSV virus burden in the older population?
I think, as mentioned before, through information and evidence, that's the best way to inform decision makers and provide them the tools also to implement their policies, because then it's justified by something concrete. So what we really need to do is to improve our surveillance, increase the amount of evidence available on burden of disease in older adults. As it was mentioned, it's increasing, and we saw an increase very recently in the recent years, but we still need some way to go. And through that information that at ECDC we try to collect as much as possible through our surveillance systems from the EU member states, inform the decision makers and show if an impact of an intervention, for instance, is there, and what is the burden of disease in different age groups and risk groups.
Thank you. Another question that's come in, what seems to be the reason for the non-implementation of the highly effective monoclonal antibodies in the newborn period? In most countries, all the data seems to support the introduction. So is it the cost? Are there any cost effectiveness analysis studies that contradicts the introduction? Philippe, what would you think there?
Yeah, so the cost effectiveness is highly dependent on the way these products are priced when they enter the market, and linked to that also the way they are delivered to the target population, and that differs a lot between countries. And we've shown that these products can be cost effective, but not at any price. That's the short of it. So there is a price level, and that depends on the country context. If you go above that, then what we call a rational decision maker would not use these products, but would use this money for something else in healthcare that has better efficiency.
Another question, I think this is also for you, Philippe, picking up on your point about the quality of life. Somebody asks us, do countries consider the impact of RSV on quality of life of parents when making decisions about interventions? Philippe?
In most guidelines for economic evaluation, this is not included. So this is for the countries all have specific guidelines for their own government to be informed. And most of these guidelines exclude this type of quality of life impact. But there's a movement, let's say, from the academics and from other methodologists trying to put it more and more on the agenda, because it's been shown for other viruses as well as for RSV that it does have an impact.
And another question that's come up asking, would vaccinating the majority of infants and the older people protect those who are not immunized through herd immunity? Eduardo, is that a factor?
It's too early to tell. We don't have data, of course, already available in the populations that can inform us about that. And the vaccines were developed with the primary outcome to prevent severe disease and hospitalization. So this would be, of course, an added benefit. We know from other vaccinations, of course, that the higher the uptake, the higher the coverage, the more likely that the circulation of the virus decreases in general, and the viral load in the vaccinated people is usually lower. But this is purely speculation at this stage in a population level, because we don't have yet the data to say that.
And Terho, anything to add on that about the herd immunity impact and the value of that?
Yes, certainly there is room for herd immunity, but I think that with the current products, I mean, maternal vaccination to protect the newborn infant, or giving monoclonal antibodies to provide protection for the newborn infant. They don't provide herd immunity to the major transmitters of RSV, which are children in daycare and children in schools. It might be good if we could do it the other way around. And there are many people who believe that if we had a so-called pediatric RSV vaccine, that would reduce RSV infections in the older siblings of these young infants, that might have a so-called cocooning effect for the babies who usually stay at home at that time. What comes to older adults, it's like we heard before, it's all too early to tell. Usually things go the direction that children transmit viruses to the older grandparents, grandmothers. This is what we know about influenza. How much and to what extent is that true for RSV remains to be shown.
Thank you. Let's squeeze in one more question before we move forward from your audience questions. An interesting point here, in both pediatric and elderly, what would be the impact of vaccination on antibiotic consumption, which of course is an important driver of antimicrobial resistance? Eduardo, is that one you'd like to pick up? There's a different aspect.
Well, surely, if you can prevent viral infections, you often can act also on superinfection due to bacterial disease. However, some of the disease that is caused in infants by RSV is not mediated by bacterial superinfection, but the highest burden is really coming from RSV itself in most cases. But in older adults, of course, this could be potentially a benefit, another benefit of the intervention.
Thank you. And just a quick point, Michaela, in terms of your own experience, the questions that were raised there from our audience about vaccination, or possibly some people having a concern about vaccination and wanting to rely on herd immunity. In your experience, is that the case? Do you come across people who think it's somebody else's problem?
Yes, sadly. And again, like we've been talking, it's about information. If they don't know the consequences, this will then get a problem. So I believe in information and talking to people.
Thank you. Well, the title of this event, The Staggering Cost of Doing Nothing on RSV, was carefully chosen. So to sum up this panel, looking at the burden, I'd like to ask each of you in turn to give, perhaps in just one quick sentence, what you would like to see done to ensure that Europe doesn't pay a staggering cost. Eduardo, what would you like to see done?
We would like to see, first of all, more investment into understanding further the burden, particularly in older adults, as it was mentioned, but in particular also to improve surveillance and increase detections. And we hope that now, with the fact that likely RSV will become a notifiable disease at the EU level this year, we hope that this will be the case.
And do we have a date on that?
Well, tentatively, I would say it's expected to happen after June, but it is to be confirmed.
Okay, well, we will keep a watching eye on that one. Thank you. Terho, what would you like to see done to avoid this staggering cost?
Well, I'd like to take a different approach to this question. As Philip said earlier, we need to be sensible and to think we cannot afford anything at any price. But I think that now that after decades of waiting, we have tools to prevent severe RSV in infants and also in the elderly population. I think it would be even unethical if we didn't even try to implement these in our programs. At least we should seriously do those calculations and not say that, okay, we are not interested in that.
Good point. Thank you. Philippe.
Yes, and I can only agree with the last summary, so I don't have much to add to that. I think we have to be careful to to make the right calculations and have implementation studies where we can look at the effects in the real world and use that to improve our estimates.
Well, evidence, yes. And Michaela, patience having the last voice and the
Thank
first
you.
voice.
Yeah, thank you. Now, in the best of words, I would say be more considerate to people you meet, treat people like you did during COVID, and respect their health as well as your own, and get vaccinated if and when you can. And if you are ill, stay home.
Well, thank you very much indeed. You've all made some very important contributions. Thank you all so much for being our first panel. Really good to have had you with us. Thank you so much. And now we turn to the next section of our event, and it's my great pleasure to introduce our keynote speaker, who is MEP Stelios Kimperopoulos, a Greek psychiatrist and politician with the European People's Party, a member of the newly established Subcommittee on Public Health, and co-chair of the Disability Intergroup at the European Parliament. MEP Kimperopoulos, welcome. Over to you for your keynote speech.
Thank you very much, you, and I'm really very happy to see you all here gathering today to discuss, let me say, a serious disease which is quite underestimated, another respiratory disease that has been grabbing headliness recently. We have seen now RSV cases are spiking in previous winter season across Europe, and how the triple demic of RSV, COVID-19, and influenza is flooding hospitals and pediatric ICUs around the world, posing clearly a significant concern, particularly affecting infants, young children, and the elderly. RSV, as you have already mentioned, is actually one of the leading causes of respiratory infections in infants worldwide, posing an enormous burden on parents and carers. And from what we are hearing here today, this is a preventable risk and thus an unacceptable risk. Beyond the impact to families and carers, we also have to acknowledge the burden on healthcare systems already strained by winter influenza infections and now also RSV. We thus need proactive messages to address RSV. As policymakers, it's crucial for us to understand the challenges posed by RSV and to work towards effective strategies to mitigate its impact on public health. We must prioritize efforts to prevent and control RSV infections, especially among vulnerable populations. By fostering collaboration, investing in research, a main point that we need to focus on, and implementing evidence-based strategies, we can work toward reducing the burden of RSV and improving the health outcomes of individuals and communities across Europe. IME projects such as PROMISE, which brings together policymakers, researchers, healthcare professionals, and industry stakeholders, are just an example of how critical collaboration is to advancing RSV research and innovation. Our challenge now is ensuring that this body of work resulting from extensive EU resources is carried forward and implemented so to ensure improved health outcomes in Europe. RSV represents a significant public health challenge that requires a comprehensive and coordinated response. I hope this conversation here today starts the beginning of next step of the RSV journey, namely the journey for full uptake of RSV immunizations and therapeutics for all above who need it. We know immunization is the cheapest healthcare prevention strategy, and we don't want to look back and realize we missed opportunities to protect our infants and our elders. Sue, once again, thank you very much for this invitation. And I think that the final results of this gathering will be tremendous.
Well, MEP Kimperopoulos, thank you very much indeed for your very powerful keynote speech there. And I think the points you make about collaboration, being proactive, innovation are all very, very important. Thank you so much for joining us. It's been really, really helpful and lovely to have you with us.
Thank you.
So in the first panel then, we heard about the burden of RSV and what doing nothing will mean for Europe's citizens and indeed the healthcare systems. But what then can be done? Let's turn now to considering that, looking at steps from research to policy, passing the baton on RSV policy. What more then needs to be achieved? What are the challenges facing member states in prioritizing the action and indeed expenditure on RSV? Where are there examples perhaps of best practice which can inform and inspire other countries? So to discuss all this, I'm delighted now to introduce to you our second panel. We have with us Federico Martinon Torres of SERGAS, which is an independent organization on public health in Galicia, Spain. He's a pediatric consultant and head of infectious diseases unit at the Hospital Clínico Universitario in Santiago. Also, Hannah Neuenek, chief physician at infectious diseases prevention and vaccines unit at the Department of Health Security at the Finnish Institute for Health and Welfare, also chairman of the World Health Organization's Strategic Advisory Group of Experts. Also joining us, we have Jean-Marie Hammer, manager at the Dutch National Immunisation Programme, a youth doctor involved in the National Coordination of Infectious Disease Control at the National Institute for Public Health and the Environment. And also pleased to welcome Monica Gappa, who is president of the European Respiratory Society and professor of pediatrics and director of the Children's Hospital Evangelicus Krankenhaus in Düsseldorf. Well, welcome to you all. Again, when we've heard from our speakers, we very much want to take the audience questions, so keep them coming. Again, you've got a fabulous panel of experts to put your questions to, so pop those into the Q&A on the platform just at the bottom of your screen. Perhaps I could start then with Federico, if I may, go to first names. With your Spanish national experience with RSV and the immunization programs that have been put in place in Galicia, what were the main challenges that you faced and how did you overcome them? Because I think you are going to be our example of good practice.
Well, thank you. Very glad to be here. And I don't know if we are really an example, but at least we can provide some hints. I think that Spain in general, and specifically Galicia, has been one of the early adopters of the recently available tools to really tackle with RSV disease. And specifically in Galicia, Spain, we started a universal prophylaxis program against RSV with the use of long-acting monoclonal antibodies. Now, why this happened and why Galicia and Spain soon after included this practice into their national immunization program, I think is the result of multiple factors. The first, of course, was to have a good knowledge of the actual burden of the disease, and part of this knowledge comes from big international efforts like Rescue or Promise that provided the necessary data, including the source data coming from Spain, but also many other local and national and regional studies. Of course, to have a tool, and as soon as we have the approval for Europe for the use of the long-acting monoclonal antibody nirsevimab, this was really a trigger, a catalyzer of what happened afterwards. And also we had in place recommendations for professional societies like this Pediatric Spanish Association already promoting and endorsing the utility and the interest of including this practice as part of the national immunization program for all infants. So with all this together in Galicia, and we can see that in the next slide, I think that the Galician authorities took some sort of pragmatic public health decision, because indeed this was a very innovative approach. There was no real life experience so far on the implementation. The studies, the specific efficacy studies for this particular drug were not available at that moment, but with all the previous knowledge, the foundation established by the detailed knowledge, having a good surveillance system in place, having the approval for nirsevimab and also specific recommendations made them take this decision and plan, I think, that a very successful implementation plan for nirsevimab. Actually, the logistics for that were planned in a simple manner, with calculating the start of the season based on the previous 10 years, and from there to prepare the rollout campaign of nirsevimab to cover all infants, including those born during the season, also those that we consider the catch-up cohort below 6 months of age at the start of the campaign, and of course those with high-risk conditions for severe RSV disease below 2 years of age at the moment of the start of the campaign. And coupled with that, we also made I would say important efforts in terms of information, education, including leaflets, webinars, including in the scope of this information and educational effort, both healthcare providers but also the lay public, which will be instrumental for the actual success or failure of any public health measure, in this case, the start of the immunization against RSV of all infants of the Galician region. And how this went, we can see in this next slide that the results in terms of implementation were outstanding. And it's true that in Spain and in Galicia in particular, we usually have very good vaccine uptakes in all age groups. However, this was a new situation. The nirsevimab had not been used before in a global perspective in real world conditions. And I think that it was the sum of good awareness by the population and the information and educational campaigns and the joint effort of the public health authorities and the healthcare providers that led to this outstanding uptakes, which is a key step for anything you can aim after implementing any measure, any public health measure into the system. And as you can see, we were able to achieve immunization uptakes above 90% for the whole group, and specifically even for the catch-up groups and the high-risk groups, in less than 2 weeks, we were able to achieve this very high uptakes before the start of the season, so ensuring the protection of the target population before the RSV circulation starts. So this first step was very successful, and I can share with you already, we move on to the next slide, the already quite outstanding impact so far. So we are weekly reporting this in a publicly available way at NIRSEGAL web page, the results of the implementation. Here you can see some of these, let's say, some more important or more outstanding data. In the left hand, you can see the cumulative weekly hospitalization rate due to RSV in those of the catch-up cohort as compared to the previous seasons, both the pandemic season, but also the pre-pandemic seasons. And you can clearly see an obvious flattening in orange compared not only to the previous season, which was abnormally high, but also to all the other pre-pandemic seasons. So we are now starting to have a decrease in the RSV activity, but we have, on the other hand, let's say, a normal activity in RSV this year. In the middle, you can see a similar approach, the cumulative hospitalizations rates, in this case, for those below 6 months, including them, part of those that belong to the high-risk group and also born during the season, but looking specifically to the highest risk group, as we have seen in the previous session, where we could see that the most of the hospitalizations actually occur in this age group. And again, we can see a clear flattening on this hospitalization rate. And in the right hand, we can see the same cumulative hospitalizations rate, but in those that were not eligible for nirsevimab administration, those in their second season. And as we can see in the orange bars, the hospitalizations rate were similar to the preceding seasons. So let's say, as expected, no effect was obtained on the use of nirsevimab, but clearly this reinforced what we actually found in those that actually were covered by the immunization campaign. So this led to an outstanding reduction in hospitalization in infants that has been estimated to be nearly 90% compared to the preceding season. So this is really part of the, or let's say, first real world evidence coming from a population level of the utility and actual efficacy in real life of this novel measure consisting on universal prophylaxis with long-acting monoclonal antibodies.
Federico, thank you very much indeed for the data there. And as you say, outstanding uptake and therefore outstanding decrease in the number of RSV hospitalizations in those very, very young babies there. So thank you very much for that information. I'm going to turn now to Hanna Noyanek from Finland. And as a representative then, Hanna, of a national public health institution, what about national action plans there? Because Federico talked about joined up systems, which seems to be fairly key to that. So what can countries do to support and prioritize RSV?
Well, thanks a lot, and excellent thank you to Federico for sharing the lessons learned in Spain, and I think that's very kind of inviting all the other countries and regions to look into on how they can proceed with their decision making, and in order for us to understand what countries actually go through. Maybe we can have the next slide, and I'll share you with my country, Finland does. It's pretty much of a merry-go-round, and let me just walk you through, because when we say that we want to do evidence-based decision making, then the decision on vaccinating universally in a program like what Galicia has now been done, then you need to have the kind of a surveillance in there saying that yes, we want to establish this group, expert group, to look into the matter and to ask the question of whether there's public health benefit from the intervention, be it the monoclonal antibody or maternal vaccination. And then we'll look into what is the vaccine safety on individual and population level. And we possibly build a transmission model answering the question on who gets infected by whom, and can the intervention also prevent that transmission. Then we also look into the cost of the intervention and build a cost effectiveness model, as Philip was earlier saying. And then based on all that, this expert group comes out with their expert opinion, which they share with, in our case, with the National Advisory Committee on Vaccinations, that then provides advice to the Public Health Institute, which then needs to consult the Ministry of Social Affairs and Health. And they usually also consult another body, Advisory Board on Communicable Diseases. And then if the outcome is positive, as in this case one would expect, at least to certain risk groups, then the ministry would give its opinion into the budget proposal, which then the parliament, in our case, would need to approve, because the national immunization program is financed by the government. Now, and only then you would then have the positive answer that yes, will include this intervention into our national immunization program, provided that it's reasonably cost efficacious. Now, Finland hasn't set a certain threshold on how much a quality adjusted life year needs to cost, but certainly if it goes too high, then it's a no-go, and then you need to kind of wait until the prices come down, and then you can repeat your exercise. So I show this to you just so that you understand that even if we have a serious burden of disease. That doesn't mean that automatically everybody is like Galicia and they make their decisions based on that. But they may have to go through this formal process so that they demonstrate that the intervention is reasonably cost efficacious. And that takes time.
And thank you. Your slide there does show a certain complexity of the system. And it was interesting, Federico mentioned about a pragmatic approach and trying to simplify things. I wonder how frustrating you would find it to that it can take a long time to get the processes in place, and perhaps there's a long delay in putting in place a very important implementation of a vaccination program.
And that very much depends on who finances the national program. If it is insurance-based, it may go much faster. But when you're dealing with public monies, taxpayers' monies, then you need to be sure that what you're doing with that money is bringing health return that is reasonably cost efficacious, just like what Philip Boitels was telling us earlier in the earlier panel. So these are the kind of thresholds where we are.
Well, thank you very much, Hannah. Let's turn now to Jean-Marie Hammer. And I wonder what are the main gaps and the opportunities in surveillance, prevention and immunization for RSV, and in terms of what's needed to ensure that any of the findings are turned into action in your experience.
Yes, thank you. Thank you for the invitation. Well, I think then we should first start with sharing the status in Holland, the Netherlands, where I'm the program manager of the immunization program. At this point, we are at a crosspoint where we have had last week a positive advice from the Health Council or the NITAC saying that that the advice is to start getting the nirsevimab in the program. So the choice for the monoclonal antibodies and not the maternal vaccination during the season with a catch-up possibility. So that's kind of they don't exclude use of the maternal vaccination, but preferably using the monoclonals. So that is the content of the advice. So in Holland, it's as Hannah showed very well illustrated that after that step, we need to wait for the Ministry of Healthcare to look at the financial part to see if it's possible to finance it into the national immunization program. So actually we're waiting now a little bit there, but of course we're not waiting. In meanwhile, we're looking at which healthcare workers could help us to realize to do the implementation. And there's a certain difficulty in Holland because of course, you want to give this monoclonal as soon as possible after birth to prevent, as we saw, that the burden of disease is in the first month, most of it. So you want to give it as soon as possible. Well, in Holland, we have this unique system that 30 to 40% of the women deliver at home. So we cannot just, if we would ask the healthcare workers, the midwives who work in the hospitals to help, then we don't have all women will not be covered, will not get the vaccine. And we have quite stringent ways of the transportation of the vaccine. So it's also not that easy if the midwives who work at homes or give birth during the night, help the women to give birth, take the vaccines with them. There's quite some puzzling work to do. It's not impossible, but it's not a usual way for us to deliver the vaccination in the national immunization program. Another option would be where all the vaccination of the national immunization program are normally given to the children is in the centers of primary health care, where the mother and child clinics, the mother and child clinics, or the parents and child, I would rather say, come for their checkups of weight, measurements, and the vaccinations. So that's another system in Holland. The pediatricians don't give the vaccinations. The primary healthcare system gives the vaccinations. In local consultories, where you come up for checkups with your kids, and the first year you come like 10 times, and until 4 years you come there several times. So that is where you get normally the vaccinations for the children. But those, the first consult that is offered to the parents, the new parents, is at 1 month. So you're actually too late to start vaccinating then with the monoclonal. So I think there I would like to stress that although we have a beautiful advice, we have a beautiful vaccine, and we have an obvious burden of disease, and maybe we will have the money, I don't know yet, but let's say we will get the money, it's still about vaccinating. It's not about the vaccination, but it's about vaccinating. And how to do that in Holland is going to be quite a puzzle. And I think that is the nice part of my job, but it's also the most difficult to get through all those challenges and to see which healthcare workers can do this.
Oh, thank you. And those points really underscore what was being said earlier about the variation across member states in Europe in terms of implementation of the policy. I'm quite struck by your figure of 30 to 40% delivering at home, which seems quite remarkable. But as you say, that brings its own challenges, as well as I'm sure some advantages in other ways. But thank you for that. Let's turn to Monica Gapper with the ERS, and I'm just interested about the longer term impact of severe cases of RSV with chronic lung conditions, that if you don't immunize and there are conditions that with RSV, what impact is that going to have in the longer term?
Well, thank you very much for asking me to take part in this very important meeting. And let me start by saying that RSV is both a burden in terms of the acute disease as well as a potential burden in terms of long-term respiratory health. And actually, from the medical society perspective, the ERS perspective as a respiratory society, the newly available vaccines or immunizations give us an opportunity to really talk about the burden of respiratory disease, and RSV in that way is a perfect example. We have heard a lot about the acute burden in infants and children as well as in older adults. But we also know for quite some time that a severe lower respiratory tract infection in early childhood and infancy has a potential long-term impact, which may affect adults after quite some time. And we have data that show that such diseases increase the risk for COPD in later life. So we are talking about diseases that no longer are infectious, but are chronic, non-communicable diseases. And this has to be taken into account when talking about economical impact. So we need to advocate for better awareness for these respiratory conditions and try to combine our efforts to fight acute disease, which will then help to reduce respiratory disease burden in the long term.
Thank you. And I'm hoping we're going to get a flood of questions coming in to put to our expert panel. You've all set out your cases very clearly there. Let's take now some of the audience questions, and do keep them coming. You can pop them into the Q&A. We don't need to give your name, but if you'd like to, that's great. Let's pick up a couple of the things that have been coming in here from our audience. Well, let's just prioritize a few of these. It's lovely to hear from so many of you. We've got one saying from Gail de Santos saying, we heard the importance of surveillance and collaboration. Although RSV is a unique disease with a specific clinical presentation, could we envisage to follow an integrated or holistic approach, utilizing existing surveillance tools in place for other diseases, which would improve education and awareness, the diagnosis, monitoring, and assessment programs? Gosh, that covers a lot. Federico, as our example of good practice, what do you make of that? Can we use the existing systems to improve things here?
Well, I think in some manner, in many countries, RSV is being built on the backbone of other good practices like those for flu, as an example. No, it needs certain adaptations, but it needs for surveillance, for the sentinel sites, for to put in place for the implementation of the different measures. Indeed, we can leverage on the lessons learned from COVID, from flu, and indeed, I'm sure that many countries are doing that. On the top of that, you need also these collaborative efforts that are also already ongoing, like the promise itself, but other efforts that are from surveillance perspective, programmatic perspective, from different stakeholders working together on the same direction. But indeed, it's not an easy question. I agree that it's a good plan, but I don't have a magic recipe to solve all the questions that Gael asked.
Anyone else on our team like to come in on that one about the use of existing tools to make sure that we get the implementation? Monica.
Well, I didn't raise my hand, but I think you mentioned the most important tools already. Sentinel surveillance data are available in many countries, and they beautifully show the burden of disease in the different age groups. And I think they will also show the impact of vaccination. So we have to follow these. It's better to have good data in the short term, really very soon available. Maybe there are better tools, but I think the Sentinel tools will give us a very good picture of what's happening.
Thank you. Hannah.
Yeah, I think the promise is a very good example on how we can actually standardize methodology. And we've been doing that in our surveillance work package on actually sharing surveillance protocols for genomic analysis. And all of this is what we earlier discussed, that we will deliver to ECDC so that this work will not be left aside once promise is over in April, but actually it's something that ECDC then can take on and work further, because we do need standardized case definitions and standardized ways of understanding on which kind of viruses are circulating and are there any mutations, which is something that we are on the safeguard once we start using these in interventions or on larger scale. So I agree. Going towards lessons learned with COVID and influenza and now RSV, there may be new viral respiratory pathogens looming in the horizon, and so we are ready to also take those on board.
Thank you. The question I think is for Jean-Marie, asking what was it that made the Netherlands favor the monoclonal over the maternal vaccine, as Spain and France also seem to be choosing this option?
Yes. There were several reasons. The most important is that they think that the monoclonal work a little bit longer. So, and that you can implement then one vaccine, and instead with the maternal vaccination, you cannot be, if the woman delivers quite early, for example, you will have to give the monoclonal afterwards too. So you'll have to have two vaccines implemented. So that's the second reason. I think those were and there were some questions about like, not entirely sure about preterm delivery on the maternal vaccine. So I said like, okay, let's just wait a little bit on there to see more clearly the effect of the maternal vaccination on preterm deliveries. So those three reasons were mainly the reason for the positive advice on using the monoclonal.
Thank you. Now, we've been focusing obviously on the value of vaccination. Anonymous has put in a point saying a vast majority of EU countries spend less than 0.5% of their healthcare budget on immunisation. Given the evidence demonstrates that immunisation programmes can not only be cost effective, but also sometimes cost saving, wouldn't it be better to use public money to invest more in prevention? Which of you would like to come first on that one? Federica's taking a breath.
For me, yes, I am in favor of investing as much as possible in prevention. Indeed, you need to have into account many other factors, like some of those have been pointed out by Hannah before, but indeed, we need to invest more in vaccines, no? And And then this is a complex discussion because it can be it changes from country to country. In countries like Spain, the money that is directed to vaccines comes from a different pot than the one that comes from the rest of the drugs. So this makes a difficult situation, and the competition is terrible. It looks like we are investing too few on prevention, and actually it may be a little bit unbalanced. But I think that the message is that we need to invest the most possible in prevention, which actually is the best investment in the present and future health of our population.
And Hannah.
Yeah, if I may add to that, it seems like we are working in different boxes, that the prevention world is really far more stringent on interventions being cost effective, whereas when we are on the treatment side, the treatments can cost almost anything once the patient is sick, and we don't exercise similar type of stringent cost effectiveness, because oftentimes it's felt that it's unethical to leave a patient unattended with their expensive drug, especially if it's a question of rare diseases. So these clearly are two kind of separate worlds.
Yep.
Thank you. And a question, Monica, you'd like to come in on that one?
Yeah, I would just like to second that, and this is not, it's speaking to policymakers, but also educating our colleagues that prevention is very important in the long term, and that we will save ourselves work and money and the patient burden of disease if we work all in the same direction. So really out of the box, beyond the acute care, even if we are acute physicians.
Thank you. Good point. Federico, a couple of points that have come in, I think, for your to take up. In the perspective of Dr. Martinon, what would be the next steps in the prevention of RSV? Implement maternal immunization, knowing the good real evidence results of the monoclonals, or advance in a prevention of adult cases? What would be the drivers? And also sort of ties in with what was the acceptability level of Spanish parents receiving immunization for their babies at birth, and the educators, how did you make that so acceptable?
Well, I will start by the easy question, which is the last one. Indeed, we had a very high acceptation at all levels. I think it was due to several factors, from information, education, but also there was a very strong season, the preceding season, that was in the minds of everybody, got a lot of media attention. So I think this increased the level of awareness on RSV disease specifically, and helped us when we finally made it available for all the population. So I think that there is no one site that fits for all the different countries and regions, but indeed information and education and carefully planning the implementation of either the monoclonal or the vaccine is very important to guarantee the success. And this has to be also led by the healthcare providers, both the nurses, midwives, physicians, pediatricians, neonatologists, that are actually in the front line dealing with the questions coming from the families. With regards to the other question, I think there are room for all the possible tools of prevention. I hope there are more coming. The more, the better. At this moment, for infants, we have a monoclonal antibody and a maternal vaccine. So I think it's a question. I mean, there is room across Europe and outside Europe for the implementation of both, and we have seen how huge the burden is worldwide. And also for the adult population, I think we have an opportunity here. Probably the level of awareness, there are other factors, let's say less maturity as compared to the angle of the pediatric side, can make slower the implementation of these vaccines, but I also think they are important to be implemented, and we also have available safe and efficacious vaccines for the other population. So the good news is that we have now very good and safe options, and the next step is to make them available for the most of the population.
Thank you. Sheena Mitchell's put a couple of points in, asking, is it possible to answer if there are any more products coming down the line which may make these options more affordable to healthcare? And specifically, she asked Jean-Marie to explain more why they had concerns about the impacts of maternal vaccine on preterm births. Jean-Marie, do you want to pick up that point first?
Yes. Well, the advisory board went, of course, into all the studies, and from the studies, they thought like it's apart from there's a little bit less effectiveness in the maternal vaccine, like compared to the monoclonal, which is more effective. So there was a big preference. They saw also that there were some study results showing some more preterm children in the treated group, in the maternal vaccine group, but there was not really statistically significant. So, but there was like a reluctance. Okay, let's see a little bit more about that. So, I guess it was not the most important reason not to. It was, I think, a compilation of those reasons together that they didn't prefer the maternal vaccination, although the advice is also not excluding completely the maternal vaccination, because if we will see that the cost or there's no availability of the nirsevimab the coming time, we will have to look in if the maternal vaccination will be a good alternative. For sure, to implement it, the maternal vaccination is easier for us because they're already given 2 maternal vaccinations in Holland by the healthcare system that is already working with vaccines. So implementing it would be a lot easier than the neonatal monoclonals. So, yeah.
And on the other point, perhaps I don't know if Monica would like to take this one up about any other products coming down the line. With your medical society hat, do you know of other things that are coming down the line that gives you optimism that this is going to be affordable for healthcare systems?
Well, this is really very difficult to answer, and I think I'm not in the position to answer this. There are surely coming more products that might be an alternative to the existing passive and active immunization products that are available. But I see that Hannah is raising her hand, so she might have more.
Thank you. Over to Hannah.
Yeah. Yeah, sure. There are several products. I mean, right now we are talking about these kind of prefusion protein vaccines, but we know that there are RNA vaccines that are preventing also RSV. Those are very much down the line. There are several other concepts also being worked on. On the monoclonal side, we now only have one monoclonal, this kind of a new type of monoclonal, but there is another product down the line that we expect to have licensure in 2025, and that of course makes this approach more attractable to the world. But putting on my world hat on, I have to say that WHO is not really looking into monoclonal antibodies for the global kids because simply there will not be sufficient amount of it, whereas with the maternal vaccination that is a more feasible approach, thinking of the children globally. And so the WHO has just recently started a working group looking into the recommendation on maternal vaccination for the global infants.
Thank you. And indeed, I think a headline even today about accessibility of the available vaccines. So a good point there. We are drawing to the end of our session, and I'd like to go back to the theme, the staggering costs to Europe of not doing anything. And again, ask each of our panelists to very briefly, perhaps just one pithy sentence, say what you would like to see done so that Europe could avoid this cost, which is obviously to healthcare systems, to reimbursement systems, and indeed to patients themselves. Federico, what would you like to see done?
Well, I think we are living now a before and after. RSV is now a preventable disease, and we are also starting to even gather real life evidence. So I think we need to move forward and try to do our best to make these tools available for all the countries, and also very specifically, as Hannah already mentioned, for those where the burden translates into death.
Thank you. Monica?
Yeah, I can only follow this. We have for the first time medicines available or vaccination available that can prevent disease. We have seen this is important for a wide age range, starting from the very young infants up to the older people. And I think we should use it, should increase our effort to make policymakers aware of this and increase the speed how to implement these new possibilities.
Thank you. Jean-Marie?
Yeah, I would like to repeat that. It's about vaccinating. So, like, everything that can speed up the implementation will help. On the other side, I think in Holland we have a problem with vaccine coverage post-COVID. There's a lack of confidence that we see. So the vaccine acceptance, I think we need to work on the knowledge of RSV in people too. So, you know, the future parents should know more about RSV. So with this, I think it would be good that clinicians stand up and show what happens in the hospitals. What is RSV about?
Thank you. And last word to Hannah.
Yes, the very same words, actually. We need to improve our surveillance, especially among the elderly on RSV. We know quite well the burden among the infants, and then we need to do a proper cost effectiveness analysis so that we can assure our decision makers that this is a worthy investment in short and long term. Thank you.
It was fantastic to hear all your contributions. Thank you very, very much indeed to our 4 panelists on the second panel, and indeed to all our speakers earlier and our MEP for a keynote speech. It's been really important to have your contributions for this very timely discussion as the work of PROMISE draws to a close at the end of April. Very exciting to hear that RSV might become a notifiable disease later this year, and to hear all your ideas about what solutions can be put in place to overcome the challenges on the implementation of RSV vaccinations. Thank you all very much indeed. Thank you to our audience. And from me, Sue Saville, goodbye for now.